Welcome to the webinar, Best Practices for Screening Patients with Chronic Kidney Disease in the Cardiac Catheterization Lab. This program is provided by the North American Center for Continuing Medical Education and is supported by an educational grant from Osprey Medical. My name is Prakash Balan. I'm an interventional cardiologist at the University of Texas McGovern Medical School in Houston, Texas. I'll be presenting this topic today along with my colleague from the University of Michigan, Dr. Hitinder Gurm. Here are my disclosures for your reference. Our goal for today is to address several learning objectives. We're going to begin by simply describing kidney anatomy and function, and then move into a discussion of chronic kidney disease as well as acute kidney injury. We'll discuss society guidelines for the prevention of acute kidney injury and identify strategies for preventing contrast-induced nephropathy, particularly hydration and contrast reduction. And we'll end by talking about the overall impact of chronic kidney disease on patients and the healthcare environment. So let's begin by talking about the heart and the kidneys and how they work together. As you know, the kidney is the primary filter for the body. All the blood volume of the body passes through the basic units of the kidney, the nephron, whose job it is to remove waste products and eliminate them in the urine. The kidney contains about 1 million nephrons, and it turns out these are very delicate organs. Once injured, they do not recover. All of the blood passes through the kidney several times a day, and literally about 2 quarts of toxins and water are removed daily from the body. In fact, it's enough volume to fill an entire bathtub each day. And that's why roughly 25% of the cardiac output goes to the kidneys. The kidneys are one of the most avid organs in terms of recipients of cardiac output. Of course, the heart plays an important role in providing oxygenated blood for the kidneys so that they can perform their important functions. But of course, there is an important interaction between the heart and the kidneys. When the kidneys begin to fail, there's upregulation of a series of hormonal systems, primarily the renin-angiotensin-aldosterone system, that results in increased vascular tone and increased afterload for the heart. And what is true for the heart is true for the kidneys. When there is decreased blood flow to the kidneys become injured, there is loss of function, and ultimately injury that is long-lasting to the kidneys. And in fact, this is a feedback loop from heart to kidneys and back and forth. When there is an acute injury of either organ, there is a series of hemodynamic changes that result in harm to both organs. They are truly connected to one another in a feedback loop. Now let's turn and talk about chronic kidney disease. Chronic kidney disease is among the most common diseases among adults in the United States. Roughly 30 million Americans are affected by chronic kidney disease. And many others are at risk for chronic kidney disease and are not even aware that they have this condition. And interestingly, heart disease is among the most common causes of death for people with chronic kidney disease. As you can see in this slide, all forms of cardiovascular disease, from coronary disease to valvular heart disease to peripheral arterial disease to arrhythmias, are more common in patients with CKD than those without CKD. Now, how do you determine if a patient has CKD? Certainly, there are lab tests. The serum creatinine from the blood is the marker that we most often use. And obviously, from the urine as well, one can look for the protein to creatinine ratio. The serum creatinine is a marker that we use because it is a waste product that is normally removed from the bloodstream by the kidneys. The higher is that serum creatinine level, the less efficient are the kidneys in terms of removing that waste product. Now, the creatinine by itself is not the best measure, it turns out, of kidney function. Rather, the estimated glomerular filtration rate is probably the best predictor of the degree of kidney disease. There are, defined by the nephrology societies, certain stages of chronic kidney disease from stage 1 through stage 5, and this is defined by the estimated glomerular filtration rate, or eGFR. Those with an eGFR above 90 are stage 1, but once you get below 90, you move into stage 2, below 60, stage 3, below 30, stage 4, and once the eGFR is below 15, we're in stage 5 kidney failure. Now, the number of patients with pre-existing CKD and eGFR of less than 60 is about 25 to 30% of the patients that we encounter in the cardiac catheterization lab. And those are the patients that are at highest risk for developing acute kidney injury. Now, in terms of the stages of CKD and the GFR, the eGFR is approximately equal to the percentage of remaining kidney function. So when we talk about an eGFR in the 30s, that's about, the patient is functioning with about 30% of their remaining kidney function. So we need to do everything we can to preserve that remaining kidney function. As we mentioned, there are a number of ways of estimating the eGFR, but by far the best method of estimating glomerular filtration rate is the National Kidney Foundation's eGFR calculator, which is actually available as an app online for free. This is based on the CKD epidemiology equation, which you see listed at the top of this slide. This calculator uses not only lab data from the patient, but normalizes it to epidemiologic data that has been gathered over time to provide probably the most accurate method of estimating GFR. There are several other methods, but the standard of care these days is to use the CKD EPI calculator. And the reason this is important, as this example shows us, is a serum creatinine of 1.2, for example, can mean many different things in terms of GFR, depending on who the patient is. For a young, healthy African-American male, a creatinine of 1.2 correlates to an eGFR of 98. He's doing well. To a middle-aged Caucasian male, a creatinine of 1.2 corresponds to an eGFR of 66, which is technically stage 2 chronic kidney disease. And in an 80-year-old woman, a serum creatinine of 1.2 corresponds to an eGFR of 46, and thus stage 3 chronic kidney disease. And we have to be sensitive to that difference in status among these patients so that we can treat them properly in the cath lab. Now, stepping away from chronic kidney disease, when we're in the cath lab administering iodinated contrast, we create this risk of acute kidney injury. And there are multiple causes for acute kidney injury. There are 3 basic categories into which these fall. One is the pre-renal category. That's because of inadequate perfusion to the kidney, typically not enough blood or volume. There may be intrinsic renal causes of acute kidney injury, i.e. damage to the tubule, which is where many of the contrast-induced nephropathies fit. And then finally, there are post-renal causes for renal failure, i.e. obstruction of the ureteral system beyond the kidney, creating reflux into the kidney, things backing up essentially. Now, the differences between chronic kidney disease and AKI. Chronic kidney disease is usually caused by long-term conditions, chronic diseases such as hypertension and diabetes. These diseases slowly damage the kidney over time and reduce their function. And these conditions tend to be progressively worsening over time. AKI, also called acute renal failure, is usually the product of an acute event, either dehydration, blood loss during procedures, exposure to nephrotoxic agents such as contrast media, and other agents. Now, how is contrast nephrotoxic? Contrast results in decreased blood flow to the kidney due to the increased blood viscosity with the contrast sitting in the bloodstream. It reduces the flow through the tubule in the kidney and can actually cause tubular obstruction and injury, and that results in increased intrarenal tissue pressure. There is also a direct cytotoxic effect. The contrast actually harms the endothelium of the tubule, creates oxidative stress, and thus cell death and injury. It also creates vasoconstriction that impairs blood flow to the kidney. Now, in terms of the definition of acute kidney injury, there have been a number of different definitions over the years, but what's used now is primarily the acute kidney injury network definition, or AKIN definition, which is a rise in serum creatinine of greater than 0.3 milligrams per deciliter over a 48-hour period. With that definition in mind, we can see that contrast-induced AKI is a growing problem that contributes to poor patient outcomes. As we look at the incidence of AKI, it has risen over the years, and in patients undergoing PCI, you can see that those who experience acute kidney injury have much higher morbidity and mortality than those who don't experience an AKI. And we'll talk more about this important data from the NCDR in a little bit. Other negative impacts of contrast-induced nephropathy: once we damage the kidney acutely and leave the patients with chronic kidney disease, that of course increases their risk of heart disease, increases their risk of long-term dialysis, and therefore increases their risk of mortality. It also has a cost acutely in terms of healthcare costs, longer hospitalization, increased 30-day readmission rates. Now, how is AKI tracked in the hospital? The NCDR CAF PCI registry, which is operated by the American College of Cardiology, is how we monitor our performance with respect to acute kidney injury. The purpose of this is to allow hospitals to compare their quality performance metrics to national benchmarks and identify potential opportunities for each individual hospital to improve their care. Now, in 2014, Dr. Tsai and colleagues actually published a wonderful study examining this NCDR data, looking at over 1 million PCI procedures performed in the early 2010s. From that cohort, they were able to extract usable data from just under 1 million patients, and they were able to identify that from all these PCI procedures being conducted throughout the United States, the incidence of AKI is roughly 7.1%. And in terms of grade of AKI, much of that is AKI grade 1, but some of these patients are actually proceeding on to need for dialysis. What are the predictors of acute kidney injury after percutaneous coronary intervention? The amount of contrast used. Anything more than 75 units was an independent predictor of acute kidney injury. The patient's age, underlying comorbidities such as pre-existing heart failure or diabetes certainly increase the risk of AKI. Furthermore, the acuteness of the cardiac presentation, those presenting with STEMI or cardiogenic shock, were much more likely to develop acute kidney injury. By far the strongest predictor of acute kidney injury, however, was severe baseline impairment in the eGFR. Now, AKI, as defined by that AKIN definition, is tracked as a quality metric by the NCDR. And this is the benchmark by which each of our hospitals is graded. So what are the society guidelines for the prevention of contrast-induced acute kidney injury? First, what are cardiology guidelines? They're rules of the road based on evidence to standardize care in the cardiac catheterization lab. They summarize published literature and provide recommendations for diagnostic and interventional procedures. The purpose is, of course, to improve the quality of care and optimize patient outcomes while minimizing healthcare costs. The guidelines are developed by the ACC, American Heart Association, and the Society for Cardiovascular Angiography and Intervention. It is a Class 1 recommendation of all of these societies that patients should be assessed for the risk of contrast-induced acute kidney injury before undergoing percutaneous coronary intervention, and patients should receive adequate preparatory hydration prior to these procedures. Furthermore, in patients with chronic kidney disease, the volume of contrast media should be minimized. In a 2016 update to the SCAI guidelines, the Society for Cardiac Angiography and Intervention indicated that the total contrast administration during procedures should be monitored in real time so that physicians have that feedback of knowing when they are pushing the limits in terms of contrast volume. Now let's talk specifically about strategies for preventing AKI. First, in terms of identifying who's at risk for AKI, the most well-known of the risk calculators out there is the Meron risk score, which was published in 2004. This risk score uses the previous rifle definition of AKI, which was a 0.5 rise in creatinine. However, it is still very applicable to today's practice and gives one an excellent estimate of one's patient's risk of AKI. Using the data from the CI study we pointed out earlier, the more of those risk factors that we identified as predictive of AKI, the more of those factors your patient has, clearly the higher the risk of AKI in any given situation. The guidelines for prevention of AKI recommend adequate preparatory hydration for anyone at risk of AKI. This is open to interpretation to some extent, as there are no well-defined protocols to guide fluid administration. The optimal hydration actually depends on the hemodynamics of a given patient. A patient with an ejection fraction of 20 and a wedge pressure of 40 is very different from a patient with an ejection fraction of 65 and a wedge pressure of 8. And we'll talk a little bit about that in a moment. In terms of hydration strategies, there have been a couple of recently published trials that have looked at what sorts of solutions are best for the patient. It does not appear that there is any benefit to sodium bicarbonate over sodium chloride, nor is there any benefit to use of acetylcysteine as compared to placebo. If there is any solution that is most beneficial, it appears to be a balanced isotonic solution, balanced crystalloids, basically lactated ringers. This was a study recently published in the New England Journal of Medicine that indicated that the overall rate of major adverse kidney events was lower in those treated with balanced crystalloids, i.e. lactated ringers, as compared to saline alone. Now, in terms of the amount of hydration with whatever solution is chosen, as I mentioned, that really depends on the patient's hemodynamics. This is data from Dr. Brahr's Poseidon trial, which was a very elegantly designed trial that indicated that what one needed was a sort of sliding scale for hydration based on the hemodynamics, i.e., if the LVDP is low, you want to give the patient more hydration, and that optimizes their outcome. On the other hand, if you're dealing with a patient with high LVDP, less hydration is probably best. As we know, we want to keep these patients on the Starling curve. We don't want to overload the ventricle, nor do we want to underfill the ventricle. Now, moving to discussion of contrast volumes, now that we've talked about hydration, contrast volume administration actually varies greatly among physicians, among interventional cardiologists. And as we've noted from the CI study, every incremental increase of 75 cc's of contrast increases the risk of AKI to the patient. So therefore, we know that reducing contrast volume is important, but it does not appear that there is any correlation between the amount of contrast we administer as physicians and our understanding of the patient's underlying chronic kidney disease. This is data from Dr. Amit Amin's 2017 study looking at volume of contrast administered based on a given patient's risk for acute kidney injury. And what this shows us is, despite what a patient's risk of AKI may be, we're giving these patients the same amount of contrast. You would think that the patients at highest risk of AKI, we would do the most to reduce contrast volume. But real-world practice seems to be the opposite of that. And that's why we need to change our practice so that those at highest risk, we can minimize the contrast volume administered to those patients. Now, what are some of the strategies that we can use to reduce contrast volume in the cath lab? Certainly, we can slow down the injection rate, use smaller syringes, mix saline and contrast, but these are not predictable methods of reducing contrast volume, and we don't want to impair visualization of the vessel as we're working on it. Typically, practices that I employ in the cath lab is, one, to limit the number of injections total, be impeccable in terms of the handling of the manifold, always try and withdraw any contrast in the line, minimize the amount of contrast that moves forward when flushing, etc. Avoid unnecessary contrast-based procedures such as LV grams or peripheral runoff. Avoid guides that have side holes simply because there's more contrast that exits into the aorta via the side hole. Use IVUS as much as possible so that you can use a non-contrast-based media to define your anatomy. Use as many landmarks as possible, particularly calcium, and avoid excessive puffing. Certainly, use of biplane imaging can be helpful because you can get 2 shots for the price of 1 contrast load. However, it is cumbersome to use biplane imaging, and at my institution, only 2 of our labs have biplane, and it's very hard to book a patient in a crowded cath lab if you're asking for biplane. While it's useful, and if you have it available, certainly use it, it's not always feasible. There are also automated injectors that can be used that may help reduce contrast volume. Certainly allows you to track contrast volume electronically, but studies have never shown that use of an automated injector actually reduces contrast volume. And in fact, using a modeling study, my colleague Dr. Gurm, who you'll hear from shortly, has actually been able to show that if you reduce contrast volume, one should be able to reduce the risk of AKI. Let's now turn to the last piece of our discussion, which is the impact of acute kidney injury on patient outcomes and economics. It is large, and this is why this is a problem we really need to focus on. Patients with AKI are 15 times more likely to be hospitalized over a 4-day period, i.e., the cost of these admissions is significantly higher. There is a 37% increase in 30-day readmissions for patients who develop AKI. And as you know, the healthcare system is moving towards a bundled payment system, and there is actually a penalty for these patients that are readmitted within 30 days. The overall reimbursement is reduced as a result of the 30-day readmission. To summarize that concept, the presence of AKI in your patients actually creates a significant economic risk for both physician and hospital, and therefore there is a strong incentive to reduce these adverse outcomes. So in summary, the costs of AKI are high for the hospital and for the patient, who's the most important person in this equation. There is no real treatment for AKI. Our best strategy is to prevent AKI. And the ways to do that are identify patients who are at risk for acute kidney injury, particularly those with chronic kidney disease, hydrate them appropriately and adequately, minimize the amount of contrast volume administered to these patients, and avoid other nephrotoxic agents. Thank you all for having me. I'll now turn things over to my colleague, Dr. Hitinder Gurm, who will be talking to you about thresholds for contrast administration.
Well, thank you, Dr. Balan, for the wonderful review. My name is Hitinder Gurm, and I'll be talking about the best practices for screening patients with chronic kidney disease in the cath lab with a special focus on contrast dose thresholds, the why, what, and how. These are my financial disclosures. I have been a consultant to Osprey Medical and have research funding from NIH and Blue Cross and Blue Shield of Michigan. Now, as Dr. Balan mentioned previously, chronic kidney disease is very important. In this webinar, we're going to cover three aspects. He's already covered the different definitions of chronic kidney disease and the impact of chronic kidney disease on patients in the cath lab. I'll be specifically focusing on the third objective. What are the appropriate contrast dose thresholds for a patient coming to the cath lab, and how do you implement a threshold management strategy that will allow you to develop a system that gives your patients the best outcome? So you might wonder, why do we care about contrast thresholds? And you have to go back to the patient who's going to get exposed to contrast is at risk for acute kidney injury. Acute kidney injury is a common problem in the cath lab. These are data from Dr. Tom Tsai and his group looking at the NCDR registry, and we have over 1 million patients, all hospitals or almost all hospitals in the United States. And what you can see is about 7% of patients will develop acute kidney injury or go on dialysis. While the number of patients that go on dialysis, fortunately, is very small, only about 0.3%, these patients have a terrible outcome. If you look to the slide on the right, you can see the patient that ends up on dialysis has almost a 30 to 40% chance of dying. They have a high risk of bleeding, and they have a high risk of myocardial infarction. Now, if you look at the patient that doesn't go on dialysis but develops acute kidney injury, about 9% of those patients will die. And this is any acute kidney injury. So if you think through it, any small increase in creatinine portends a patient that has a very high risk of having an adverse outcome. These patients stay in the hospital longer, their healthcare costs are higher, and as such, their long-term outcome, even after they leave the hospital, their long-term outcome is poor. Now, I would like you to think through the underlying pathology of why we focus on these aspects. So the underlying hypothesis of contrast-induced kidney injury is very simple. It's almost the basic elementary toxicology. So the likelihood of contrast-induced kidney injury is directly proportional to the amount of contrast that reaches your kidney, or specifically through the glomeruli into your renal tubules. So I'll repeat that again. So the likelihood of kidney injury or the tubular injury is directly proportional to the amount of contrast that gets to the tubules. It sort of makes sense. If you expose an animal, a bacteria, or a cell to a toxin, more toxin it's exposed to, more likely it is to suffer injury from the toxin. So let's look at what this means in practical terms. So if you have a patient that has chronic kidney disease, that patient has a smaller number of nephrons. So for the same amount of contrast, those nephrons are exposed to a larger amount of contrast. Take a patient that is dehydrated, or take a patient that is in shock. So these patients have already reduced their glomerular filtration. That leads to a more concentrated urine, but more concentrated contrast in the tubule. And finally, if you give more contrast, then the patient's kidney is going to see more contrast. So going back to the concept, if you have somebody coming into the cath lab who has chronic kidney disease, they're going to be at higher risk. If somebody's coming into the cath lab who's dehydrated, they're going to be at a higher risk. If you hydrate them well, you'll dilute the amount of contrast that they get, so you're protecting that patient. And if you have a patient coming into the lab that gets a lower amount of contrast, that patient's risk is going to be lower than a patient that gets a higher amount of contrast. So that is the underlying hypothesis. So then you take it to the next level. What can we do to prevent acute kidney injury? Well, you can do two things. In the acute phase, you cannot change the patient's chronic kidney disease status. So if you have chronic kidney disease, you have chronic kidney disease. If you have normal number of nephrons, you have normal number of nephrons. But the patient in the cath lab, you can modify two things. You can modify the level of hydration, and you can modify the amount of contrast. So if you make sure your patient is well hydrated, you will automatically reduce the likelihood of acute kidney injury. Second, if you minimize the amount of contrast, you will reduce the likelihood of acute kidney injury. So let's go over these two factors over the next few minutes. So there are many hydration strategies, and there are multiple trials that have supported the broad concept of ensuring patients well hydrated. So I'm not going to go into the details of one hydration strategy versus another, but simply how do you practically apply hydration in the cath lab? And in the state of Michigan, we have a consortium. All hospitals that do PCI work together to improve quality. And we've come up with a very practical approach. The first step is to make sure the patient comes to the cath lab well hydrated. So we make sure the patient drinks enough fluid coming into the cath lab. The second part is then once the patient's in the cath lab, we make sure that they get well hydrated in the cath lab. And so for very specific data, we look at the oral hydration. So we don't tell our patients to be NPO anymore. So the NPO status for patients coming into the cath lab nowadays is no fatty foods for 8 hours, no other solid food or milk for 6 hours. But we encourage them to drink fluid until 2 hours before the procedure. In very practical terms, I tell my patients, when you wake up, drink a glass of water, and then 1 hour after that, drink another glass of water, and then an hour after that, drink another glass of water until 2 hours before your procedure. So if your procedure is scheduled for 8, you keep drinking like that until 6 a.m. Now, elderly patients generally don't like that because that means they have to stop on the way to go to the bathroom. That's okay. You have to specifically tell them that this is good for your kidneys, and they'll do a very good job of making sure that they follow these orders. And this is a very effective strategy at making sure that your patients are well hydrated coming into the cath lab. The nice thing about this is patients like it. Nobody likes to be thirsty while you're waiting for your procedure. Most patients don't have the procedure at 8. While we schedule them early, they keep waiting and waiting, and when you're waiting and you're thirsty and you're hungry, it is not good. So patients like being told that you can have something to drink, or rather actively being encouraged to drink. So the second part is once the patient's in the hospital, we make sure that they're well hydrated using IV fluids. And we've used only saline because all the data would suggest that there's really not a benefit of saline versus bicarb as long as you make sure the patient's well hydrated. So coming into the cath lab, we pre-hydrate patients, and we make sure almost everybody gets either 3 ml per kilo over an hour or 1 ml per kilo for 1 to 3 hours. For a patient that has severe valve disease or is currently in heart failure, don't give them IV fluids before they get into the lab. Because what you do is you take them to the cath lab, you measure an LV-EDP, and then you hydrate based on the LV-EDP. So the Poseidon trial, which I think is a landmark trial in hydration, clearly showed that LV-EDP-based hydration is far superior to the standard method of hydration that we were using prior to that. So a patient comes into the cath lab, you check their EDP, then based on that, they either get 1.5 or 3 ml or 5 ml per kilo for 4 hours. Now, the key thing to remember is that there's a maximal ceiling. Our patients are getting bigger and bigger, so you use the maximal ceiling of 100 kilos. If your patient weighs 100 kilo and the EDP is 12, you're going to give them 500 ml. I know it seems like a lot. 500 ml per hour, 4 hours. On the other hand, if the patient weighs 150 kilos, you still use the same because the intravascular volume is probably not that much greater than a patient that is a 100-kilo patient. So I hope I've convinced you that you can actually hydrate patients very easily if you follow this simple algorithm. Oral hydration before they get into the cath lab, IV hydration in the cath lab, and use the Poseidon score or the Poseidon strategy to help hydrate the patient. Now let's switch to contrast volume. So contrast volume is something that until recently we haven't really paid as much attention to as we like. So I would like to go through sort of the data that supports why we should be thinking of contrast almost as a necessary poison. So this is work from our lab. This is data showing contrast volume and acute kidney injury in a rabbit model. So what's happening here is we take a rabbit and we give them different concentrations of contrast based on the body weight. And as you can see, as the contrast volume goes up, so we go from green to red to black to blue, the amount of kidney injury as measured by serum creatinine goes up. So clearly showing a toxicity effect of contrast that is directly proportional to the concentration of contrast a rabbit is getting. And when you look at the kidneys, you see this effect. So on the left side, we have 10 grams of iodine per kilogram of ioxylon. So this shows significant injury. These are markedly swollen proximal tubules, and you can see inflammation even in the glomeruli. And then on the right panels, 2B and 2D, you have a rabbit that got 2.5 grams iodine per kilogram. And in this rabbit, there is some swelling, but it's markedly less. So what I was surprised by was that even with a smaller amount of contrast, which actually corresponds to what about 10% of the patients in the cath lab are getting in contemporary practice, you will see some degree of injury in a healthy rabbit. This is a rabbit that has no chronic kidney disease. Now, when you take this to a population, we see the same effect. So these are data from our group. We looked at about 50,000 patients in the state of Michigan that underwent PCI, and we looked at the ratio of contrast volume to creatinine clearance. So we looked at if your creatinine clearance is 60 and you got 60 ml of contrast, your ratio is 1. If you got 120 ml of contrast, your ratio is 2, and so on. So what you see here is the yellow bars are showing the likelihood of the patient developing contrast-induced nephropathy. The red line suggests the likelihood of the patient developing nephropathy that required dialysis. These are patients who were not on dialysis coming into the lab, but after a few days they ended up on dialysis. So what you see is that going from a ratio of about 2, the risk is fairly flat, and then it starts to escalate as you go up to about 3. Then it really goes up till about 5, and then obviously it is very high in patients that got 5 to 10 times the creatinine clearance. So if you got a contrast dose that was 5 to 10 times your contrast dose, these patients obviously had a very high risk of developing acute kidney injury or of going on dialysis. Now, it's important to remember that for this analysis, we excluded patients who got more than 10 times their contrast. There were patients in this cohort that got more than 10 times the creatinine clearance, but we excluded them because we believe that there was something really odd either about the circumstance or the environment. But what this shows is in contemporary practice, we will see an increase in risk of acute kidney injury as you increase the amount of contrast in relation to your creatinine clearance. When we look at different subgroups, the result holds, and it's actually quite interesting. So if you look at these panels, the first panel is elective PCI. So what's interesting about this is that if you have contrast volume to creatinine clearance ratio less than 2, your likelihood of contrast-induced kidney injury is very low. But most importantly, nobody in this group ended up on dialysis. And then if your ratio is 2 to 3, your risk goes up, and if your ratio is more than 3, your risk goes up dramatically. Same thing happens in patients that undergo PCI for STEMI, patients that underwent PCI for non-STEMI, And in patients in shock, there were actually very few patients who got contrast to creatinine clearance ratio of less than 2. The risk goes up as you get a dose greater than 3. So these data were quite strong. They changed our practice, but they also changed the practice in other labs and then have been validated by other groups also. So how do you reduce contrast volume? So I hope I've convinced you that contrast volume, especially in relation to renal failure or renal function, so if you adjust your contrast dose based on renal function, it's a very important risk factor for acute kidney injury. So the first thing to do when you want to reduce contrast dose is that you have to have a culture that recognizes the importance of kidney function in a patient undergoing cardiac procedures. So when a patient comes to the cath lab, in our lab, we confirm GFR and we confirm contrast thresholds 2 times or 3 times the GFR in the timeout. We switch to GFR because the data are almost interchangeable. In a large cohort, it makes a difference. At the individual patient level, it doesn't really make a difference. But since our lab reports GFR, we found it easier to use GFR rather than switch to creatinine clearance. So a patient coming into the cath lab, part of the timeout, we confirm what is their GFR, and then we confirm the contrast thresholds. And then there has to be a system that there's a routine feedback to the lab on the contrast used in each case. So if I do a procedure and I exceed a contrast threshold, at the end of the case, we'll do a debrief as to why we exceeded it and what we could have done to prevent that. Most of the time, we actually end up using much less contrast than the threshold, in which case it's always good to acknowledge your colleagues who help you through the process. We are in a teaching institution, and I always make it a point to acknowledge my fellows when they use fairly small amount of contrast. In patients that are high risk or intermediate risk, you can use other strategies. So first and foremost, you should almost always avoid an LV-gram or an aortogram in these patients because you can get the information using other means. You can use an echo, you can use MRIs, you can use non-contrast CT scans. You can use other methods that will give you the same information. In the cath lab, we find biplane to be a very useful tool. And recently, we've started using the DyeVert system. That has also allowed us to significantly reduce contrast. And then in patients that are extremely high risk, so a patient that has a predicted risk of acute kidney injury of 10%, 15, 20%, then we can use what I consider extreme minimization of contrast. You use a lot of IVUS, you sort of wire and then IVUS to size the vessel. You use the IVUS to confirm your stent is well opposed, and then sort of pretty much avoid contrast. Dr. Ali from Columbia, he's been doing procedures using no contrast. I haven't ever been able to finish a procedure without taking at least one final picture. I always like to make sure at the end of the case I have one good picture to confirm there are no complications. But there are operators who are doing procedures with no contrast. And obviously it goes without saying that it helps to stage a procedure. You can do the diagnostic in one setting in these high-risk patients, let the kidney function recover from the contrast dose, then bring them back a week or 2 later and perform the PCI. So one of the questions that I'm often asked is there value to having dedicated devices? And I think the answer is yes. The answer is yes because I've seen a dramatic decline in the amount of contrast when we have a DyeVert from Osprey being used in the cath lab. Now, most of you may be familiar with this device already or may be using this device, but for those who are not, I'll just like to give you a simple idea. So basically, if you think of a contrast injection, when we perform a contrast injection, most of the contrast goes down the coronary, but actually a significant amount will reflux into the aorta and gets wasted. So Dr. Kay's lab from Australia came up with this great idea of creating a system that prevents that reflux. So it minimizes, it doesn't totally take it away, so you can still see the ostium. It minimizes the amount of reflux that goes down the aorta while maintaining good flow into the coronaries, so maintains the image quality and takes away that unnecessary what I would say contrast that is not really important to the patient, but it's sort of extraneous in waste, so it reduces that. So it significantly reduces the amount of contrast that the patient's kidneys are getting. The second part to this device is it measures the amount of contrast that you're injecting. Now, I think that is probably as important as the first part. In my view, and I might be wrong on this, there's no data. In my view, just knowing how much contrast you are going to inject, setting a threshold, it forces you to sort of change your practice. You sort of might even forego doing some extra injections. And if you know what your threshold is, you're going to be well under that threshold. It's almost always the case that when you set a bar, almost everybody in the cath lab will meet that bar. I think that plays a very important role in the reduction of contrast that is being seen when this device is used. Now, this device has been tested in controlled trials. Dr. Desch from Germany, his group, they randomized patients to control angiography or use of DyeVert, and they showed that you could reduce the amount of contrast by about 40% or so. So an absolute reduction of about 40%. In mLs, it translated into about 40 mLs or so. And in my experience has been pretty much the same, that you save about 40% of contrast compared to what you would have if you had not used DyeVert. So it's not just a statistical significance to me. More importantly, there's a clinically meaningful reduction in contrast use that we see with this device. Now, you might ask, is a reduction in contrast important? So these are data that we published looking at trends in contrast use. These are hospitals across Michigan, all hospitals, and they use a variety of methods. So there's not really about one method or another. It doesn't matter what do you do. What matters is how you reduce the contrast. So I just want to be clear. The important thing is you reduce the amount of contrast that you use, irrespective of whatever method you take. So what you see here is a graph that shows in the bars the contrast volume that exceeded 3 times the GFR. So you see a decline in those bars. So the proportion of patients across the state where the contrast dose exceeded 3 times the GFR went down significantly. The average amount of contrast that was injected in the case, the blue line, declined over time, and the risk-adjusted acute kidney injury numbers came down in a fairly dramatic fashion over this time. So very powerful data. And sort of a validation of this idea, actually validation of 2 ideas. One, a group of hospitals working together, learning from each other can have a significant impact on quality. And second, focusing on contrast-induced kidney injury, you can actually reduce the likelihood of acute kidney injury in your patients. Now, one of the interesting things that happened as we shared these data was that the curve shifted quite a bit to the left. So these are the procedures that were performed in Michigan in more recent years. And what has happened is while we were focused on reducing the number of patients where we exceeded contrast volume more than 3 times the creatinine clearance, there was a push by some operators to take the contrast volume down even lower. So in the last couple of years, what I call ultra low contrast, so that is contrast volume less than creatinine clearance. So if your creatinine clearance is 30, you're going to do a PCI with less than 30 ml of contrast. That actually happened in 13% of the cases. So fairly impressive. That number of operators in the state adopted this practice, and they were able to do these cases with very low contrast. And what you see with this is the likelihood of AKI is very low. So the likelihood of acute kidney injury in these patients where the contrast volume is less than the creatinine clearance was 1.5 unadjusted, 2.2 adjusted, and you compare it to the threshold that we had been advocating for prior to that, which was creatinine clearance, contrast volume to creatinine clearance ratio of 3. It was significantly improved compared to that. However, if you look more closely, the most of the benefit is in patients that are at intermediate or high risk. So if you really want to see the benefit, look to the bars on the right. These are patients where the predicted risk of acute kidney injury is more than 7%. So here, if you are using less than the creatinine clearance, if your contrast volume is less than the creatinine clearance, the risk of AKI is 10%, versus if you're exceeding 3 times the creatinine clearance, your risk is 20%. So almost doubled. And then obviously, if you're using contrast volume between 1 to 3 times the creatinine clearance, your risk is about 13 to 14%. And on the other extreme, if your predicted risk is less than 1%, the ratio still holds, the benefit still holds, but the absolute difference is marginal. So I would like to say that we can be a little more targeted with using ultra-low contrast. I don't think we have to do it in everyone, but in patients that are at high predicted risk, this is using the BMC2 SCAI calculator. You can use any risk model, but simply if you take intermediate or high-risk patients, these are the patients that will benefit the most from being highly focused on the amount of contrast you're injecting in your patient. Now, you might say, well, is this something that is doable, and how are different hospitals doing? Well, the biggest predictor of who got very low contrast is the operator. So there were some operators in the state that were very good at this. So you see on the slide 2 graphs. One on the left is the proportion of ultra-low contrast by operator, and on the other side is percent of cases at a given hospital. So you can see in the hospital, there were hospitals where only about 5% of patients were treated with ultra-low contrast, and others were almost 20 to 25% of patients were treated with ultra-low contrast, but the average is 13%. And same for operators, but for some operators, they were doing this, they were following this rule in almost 60% of their cases. Well, one operator. While more commonly, there were operators that were doing this in somewhere between 20 to 30% of their cases. So I think it may be that in your lab, you have one operator or two operators or maybe more who are really focused on contrast. And it may be that you have to develop a policy that you take your high-risk patients with respect to the risk of kidney injury and funnel them to those operators. So those operators become focused on this, and it also will be better for the patients and will be better for the health system. And I'll go over some of the reasons why it will be better for the health system in a second. So I think I'd like to come back to this idea of why do we care? Well, one, we care because acute kidney injury increases mortality and it increases morbidity. These patients who have acute kidney injury, they are more likely to die during the hospitalization. They're more likely to die after the hospitalization. They're more likely to get readmitted. And most of the readmissions happen because of heart failure and fluid-related problems, which sort of makes sense. If your kidneys are not working well, you're more likely to end up with volume overload and you're more likely to get readmitted. It has also been a medical legal issue on both sides of the spectrum. There have been cases where patients got acute kidney injury and there have been legal action taken as a result of that. And then also some patients who were denied procedures because the perceived risk of contrast injury was so high. And I think we have to be sort of balanced because there are patients who will benefit from having a contrast-based procedure, but with adequate preparation, we can get them through that. I think that's the key thing. We want to be focused on doing the right thing for the patient, and it often means doing the procedure, but doing it in a way that is safe and that minimizes the risk to the patient. One of the other aspects I mentioned is cost. So this is work from our group showing that the average cost of contrast-induced acute kidney injury is somewhere between $8,000 to $9,000. Other groups have shown similar numbers. Once you adjust for everything else, the added cost of care for patients that develop contrast-induced kidney injury runs somewhere between $9,000 to $12,000, depending on the study you look at. So obviously very important for society to focus on this problem. A question that's often asked, is this an association or is this a causation? And obviously this is a tough question to answer, but we know that patients that develop acute kidney injury or animals that develop acute kidney injury, they don't heal so well, their myocardial healing is altered, there's increased risk of thrombosis, there's increased risk of bleeding, so it's paradox. You are more likely to bleed and clot if you have acute kidney injury. But then some of the drugs that we know that have such an important effect on cardiac health, ACE inhibitors, angiotensin receptor blockers, aldosterone antagonists, we can't use them in the setting of acute kidney injury. The potassium fluxes that happen, the electrolyte disturbances that happen in the setting of acute kidney injury, they're more likely to increase your risk of rhythm problems. All these things in combination are potentially likely to increase your risk of death. However, these are all associations. I think the strongest evidence of why acute kidney injury matters comes from the long-term follow-up of Poseidon. So remember, Poseidon was a trial of LV-EDP-based hydration versus standard hydration. So everybody got hydrated, and this trial showed there was a significant reduction in acute kidney injury using an LV-EDP-based hydration. So what you see in this trial, though, is that on long-term follow-up, patients that got the more aggressive hydration strategy, not only did they have less AKI early on, they were at a much lower risk of long-term adverse events at 6 months compared to the group that was the control. This sort of suggests that if you prevent acute kidney injury, you will have a significant impact on the patient long-term. So not only are you reducing that change in serum creatinine that we pick up in the hospital, but that will translate into better outcome for your patient long-term. So in conclusion, I hope we would all agree that prevention of AKI is good medicine. It is a clinically relevant endpoint. It is something that is of real importance to our patients. It is something that is easy to measure. It's easy to predict which patients are at risk. It is an actionable problem. We have prevention strategies, hydration and minimization of contrast that can be easily applied in a practical fashion. And I do hope that you would consider these in your cath labs and will help improve the care of your patients, improve both their renal health as well as their cardiac health long-term. So I want to thank you for your time. And with that, I'd like to conclude this webinar. Thank you so much.